Good evening to you all and thank you for the opportunity. My heading is Guidelines on Management of Epiphora during Infancy. So, this is the most common vexating symptom where parents come with our clinic that child is having excessive tearing. Before going to the topic, first we have to know what are the causes for the excessive tearing. It can be either reflex or decreased drainage, but the most common cause is decreased drainage, which causes nasolacrimal duct obstruction. It can be either due to punctal malposition and anomalous drainage system as well. In addition to that, we have to consider reflex causes as well. That can be either lid causes blepharitis, epiblepharon, conjunctival causes such as conjunctivitis, and corneal causes such as keratitis, and congenital glaucoma, which we should not forget if a patient comes with the epiphora. When approaching a child, first thing we have to ask from the parent is onset. If the onset is soon after birth, we have to consider NLDO as our first differential diagnosis. Then, if it is acute onset, we have to think for the reflex causes as well. Then we have to ask for the association. If the child is having photophobia in addition to the epiphora, if it is so, the most probable cause will be either congenital glaucoma or some inflammations in the conjunctiva that can be either due to uveitis or keratitis. Then whether it is associated with the pain. If it is so, we have to exclude the foreign body and other things such as keratitis. And whether the child is having discharge in addition to the tearing. If the child is having discharge also, if we are suspecting congenital nasolacrimal duct obstruction, the obstruction is in the distal part. If the child is having tearing only without discharge, the abnormality will be in the proximal part such as punctal side or in the canalicular side. Then we have to ask the mother whether the child is having watery nose as well in the same side. If it is so, the block is unlikely. Then examination part, first we have to look at the child and we have to externally see whether the child is having conjunctival ingestion, which is suggestive of conjunctivitis, whether the child is having periocular excoriation, and we have to assess the tear film of the child. Usually the tear film size height is less than 1 millimeter, but in child with epiphora, especially in child with congenital nasolacrimal duct obstruction, the tear film size will be more than 2 millimeter. Then we have to assess circumcorneal ingestion. Why it is important here is because sometimes the retinoblastoma patients present with pseudohypopain and they may mimic anterior uveitis. So we have to consider this in our differential diagnosis as well. And other thing is we have to see whether the child is having any mucocele, and we have to see whether child is having buphthalamus and diffuse corneal edema with corneal haziness. This suggests congenital glaucoma. Then we have to examine the child with a slit lamp. We have to assess the punctum and lid, conjunctival inflammation, and corneal, whether there is any aberration, foreign body or ulcer, and we have to evaluate the anterior chamber iris lens for the features of uveitis, and we have to measure IOP in order to exclude glaucoma, and we have to do the fundus examination. We have to evaluate for the cup-disc ratio, and we have to thoroughly examine for the fundus if the child present with features of uveitis in order to exclude retinoblastoma, and we have to do the CPR because if the child is having unilateral congenital glaucoma, child may develop myopia on that eye. For that, we have to do the CPR as well. Then after that, we have to do the fluorescein testing where we apply the 1% fluorescein for the bilateral inferior conjunctival fornix, and we have to wait for 5 minutes. Then we have to reevaluate the child with a slit lamp. If the child's tear drainage system is patent, usually within 5 minutes, the fluorescence will disappear. But if it is persist, the most likely diagnosis is nasolacrimal duct obstruction. This is 90% sensitive. So, we will come to our main cause for epiphora in children, that is congenital nasolacrimal duct obstruction. Here, usually 20% of the infants get nasolacrimal duct obstruction because usually the nasolacrimal duct developed as a solid canal in early developmental age, and it canalizes in the late gestational age. And the canalization starts from the mid part of the nasolacrimal system, then it proceeds both ends. So this is why we get the obstruction in the distal part, that valve of Hasner, where we get the membranous obstruction, and sometimes we may get the membranous obstruction at the punctum as well. And they present within few weeks of birth. The symptoms will start within few weeks of birth, and usually they will resolve with time. With maturation, the excessive tearing will resolve. So the presentation will be the child is very well, and the child doesn't have evidence of irritation or photophobia, and the child is having white eye, and there is increased tear meniscus, and periocular skin excoriation will be present, and stickiness or crusting of the lashes will be present. Then they may develop mucocele as well. So we have to do, as I previously mentioned, we have to do the fluorescein strip test, and we have to tentatively diagnose that it is a congenital nasolacrimal duct obstruction. Then in management part, as the clinical cause of nasolacrimal duct obstruction will resolve by 1 year in 96% of the patients, we can conservatively manage up to certain age. So, here for the conservative management, the most important thing is we have to educate the parent regarding the natural history of the congenital nasolacrimal duct obstruction. And we have to make the parent to understand that the child will get cured by this age. If it is not, we can intervene. Then we have to advise regarding the complicated features such as dacrocystitis and preceptal cellulitis to the parent as well. Then we have to advise the mother or father regarding the massaging of the eye. Here we ask the parent to press with the index finger in between the nose and the eye, just below the medial canthus. It has to be done 3 to 6 times per day, which will help in 2 ways. One thing, it will empty the stagnated fluid, which will help prevent the infection. Other thing is, it will increase the hydraulic pressure, so it will try to break the membranous obstruction. So in Krigler, mentioned in his article, according to his 7-year study, that he has 100% success rate with the massaging. Without any intervention, the child get better by age of 1 year. Then for the periocular excoriation, we can ask parents to apply Vaseline or paraffin material. Then regarding antibiotics, we don't have to use antibiotic if the child is having white eye with epiphora. In Jashura Tekashi's study, he mentioned that there is no evidence that antibiotic eye drops significantly promote the spontaneous resolution of congenital nasolacrimal duct obstruction. Instead, by using the antibiotic, they replace the normal conjunctival bacterial flora by pathological resistant bacterial flora, which will lead to the infant will, because the infant's immune system is unable to eliminate the resistant bacterial flora, this lead to be a carrier of the resistant, the infant will be the carrier of that resistant bacterial flora. So Antibiotic eye drops completely unnecessary in conservative therapy for pure nasolacrimal duct obstruction. Then if we manage conservatively, but if it is not settled, we have to probe the child. When to probe is the next question. Usually, the congenital nasolacrimal duct obstruction will resolve spontaneously by 1 year in 96% of patients. This is the normal sequelae of congenital nasolacrimal duct obstruction resolving period. It resolves usually by 12 to 18 months, 16 months. This article revealed that spontaneous remission occurred throughout the year and 96 had resolved before the age of 1. And this, after 1 year, probing give better outcome in compared to the conservative therapy. Here that Young mentioned that 74 overall cure rate for probing was 74% compared with 60% for spontaneous resolution. So timing of probing depend on a natural history, because if the child is presented with dacrocystitis or any complication or mucocele, of course we have to intervene then and there. If not, if the child is well, we can wait up to 1 year without probing. Then severity, then parental request, because if the parent requests that they wanted to wait up to 2 years, just we can wait up to 2 years. Here the dilemma comes that age, if we delay the age of probing, the probing success rate will be reduced, but not as such. The probing success rate reducing with the age because they are having complex nasolacrimal duct abnormalities, not simple membranous obstruction. That is why the probing success rate will reduce with the age. That is not because we delay the probing. Then how we are going to probe? First we have to dilate the punctum with a punctum dilator. Then we have to insert the probe initially 90-degree vertical. Then we have to insert the probe parallel to the lid. Then after achieving the hard stop, we have to turn the probe 90-degree and we have to advance with free of resistance up to downward and laterally. Probing is a blind procedure, depends on the awareness of resistance to probe as it passes through the system. So we have to have that experience while we are probing the child. After probing, if the symptom persists after 1 month of probing, we have to think that it is a probing failure. So we have to think the causes for probing failure. It can be due to the unable to create the anatomical patent pathway, or it can be due to physiological epiphora due to pump failure, or it can be due to complex abnormalities, which will be associated with Down syndrome, Lat syndrome, and other syndromic babies. So if the probe fails, we have to identify the cause for failure through endoscopic probing or dacrocystogram. Then we have to treat them with surgically, either intubation or dacrocystorhinostomy according to the pathology. So here my take-home message is antibiotics should be avoided in children with white eye and epiphora. Thank you.